Good morning and welcome to the DSRIP Project Implementation Plan 2.b.viii Hospital-to-Home webinar. This morning we will not be taking any questions. However, at the end of the webinar there will be an email address for you to send feedback to. I'd like to turn over the presentation to Colleen Florio, who will get you started.
Good morning, welcome, and thank you for taking part in today's webinar. We will be providing you an overview of the DSRIP project work plan for Project 2.b.viii Hospital-to-Home Collaborative Solutions. In addition, today's agenda includes brief updates on governance and project financing. As Heather mentioned, we'll be taking questions via email, and at the end of the webinar, we will provide you with instructions on how to give feedback to AHI on the implementation plan. Let's begin with the governance update. The governance milestones you see here have been set by the New York State Department of Health and are not expected to change. The PPS governance must be finalized by September 30th of this year, following which the PPS will establish the clinical governance structure and the reporting processes by the end of this year and into the first quarter of next. DOH recently released key information in the funds flow and Newco requirements document in late June on what is and what is not allowable in the design of governance. What we now know is that the PPS lead entity, which is AHI, cannot delegate any authorities without written approval from the Department of Health. What the lead entity can do is develop a shared governance model to support collaborative decision-making across the PPS's 9-county region. Two additional requirements for that governance are the last two bullets. All aspects of ownership and control of the PPS governance must reside with safety net providers. An LLC structure is not allowable. Governance must be with a safety net, not-for-profit organization. The next steps in formation of governance are that AHI's members and board, along with the PPS Steering Committee and the Regional Health Innovation Team leadership, will take part in a series of meetings in July and August to review in more detail the requirements that DOH has put forth and how that impacts the options in front of the PPS in terms of governance design. In addition, AHI has elicited proposals for legal consultation. Governance will be finalized by the September deadline. Failure to do so would impact funding. Just a few brief words on project financing. The PPS is required to finalize the PPS's finance structure by the end of this calendar year, which is DSRIP Year 1, Quarter 3. As you know, contracting has not been completed. We have been waiting for the funds flow and Newco requirements document that I mentioned to you earlier. This document answered several of our questions about what is and is not allowable in the funds flow distribution. One such requirement is that 95% of the funding flow to or through safety net providers. Here you see a diagram of the flow, showing the majority of the dollars flowing to safety net providers, including the PPS lead, which itself is required to be a not-for-profit safety net. The safety net providers may then in turn establish contracts with other organizations as needed for project implementation. The PPS will enter into performance-based agreements with performance partners. Performance partners are safety net organizations that are willing to share risk with the lead entity. These performance partners may then in turn enter into contracts with other organizations. They may contract with organizations that do not have safety net status, and they may enter into contracts for services. In other words, non-performance-based contracts. We do expect that the lead and the partners will need a variety of services that we will be partnering with community-based, non-safety net, and other types of organizations. The contracting entity, in some cases, will be the PPS, and in other cases, it will be a performance partner. It is that contracting entity that will determine the nature of those agreements. Note that submission of detailed work plans and budgets may be a deliverable in an agreement with a partner. There is no requirement at this time from the Department of Health for the PPS to submit project-specific detailed budgets. Now, on to the important part of today's agenda. We will be reviewing the current draft of the implementation plan. You will notice that the Hospital-to-Home Collaborative Solutions Project does not have a fully developed implementation plan. At this time, the project lacks a project manager, and as such, we have not convened team meetings. Therefore, what you are seeing is a rough outline that will need much more detail added over the next 2 weeks. We invite you to contribute to the development of the plan, and again, we will explain at the end of the webinar how to submit feedback. I'll move on now to an overview of the implementation plan. The following slides will show you the requirements and target dates. The requirements have all been predetermined by the Department of Health. The task before us now is to fill in the sub-steps and the target dates. The implementation plan that is due on July 31st will drive all subsequent reporting. Therefore, it's important that the PPS hit the right level of detail. We need to develop the implementation plan so that it provides the Department of Health with enough detail to illustrate that we understand the major steps that need to be undertaken to meet the requirement and how those steps interrelate. The timeline is important. We need to be sure that any steps that are dependent on others precede them in time. We also need to build the steps towards the target date for meeting all of the project's requirements. I'll explain more about that in a moment. Again, your team will need to create a more detailed plan in order to generate a budget and to allow your management team to oversee progress internally in your organization. But those detailed work plans and budgets are not being sought by the Department of Health or by AHI at this time. As I mentioned earlier, submission of those work plans and budgets will likely be a deliverable in a contracted agreement. As you listen to today's webinar, or after you've watched, please take a moment and consider the questions shown here. We value your feedback. In fact, we regret that we have not been able to convene a face-to-face meeting for this team to discuss these questions as a group in advance of the 7/31 deadline. Please consider if the steps shown are comprehensive enough. What are some steps that you would add? Are some steps unnecessary to achieve the requirement? And if so, which ones? Is the step clearly stated? How would you reword it? Does the flow of steps and target dates seem reasonable, keeping in mind that we are bound to the speed and scale commitments that we've previously made? And of course, any general feedback is welcome. For the Hospital-to-Home project, the speed commitment that is in place is that all participating sites will meet all project requirements by March of 2017. This is also known as DSRIP Year 2, Q4. All participating partners or sites are required to have met all the project requirements by this date. Failure to meet the date will impact funding. The following series of slides shows you the project requirements, as well as steps to meet that requirement and target dates. You'll see our first step is to assemble a rapid response team. The step shown is establishing the procedures and protocols for that team. In addition to the steps shown here, there will need to be a variety of steps to determine the appropriate composition of the team, the organizations that are those individuals for the team, as well as any position descriptions or job requirements. Some of the steps that will be added may have already taken place. For example, many of you on the phone are with partner organizations that have already committed to being part of a rapid response team, and you've already made clear how you see your organization staffing the rapid response team. Those steps that may have already been completed will also be added to the 731 implementation plan. This first submission of the implementation plan serves as a plan and our first quarterly report. Therefore, DOH would like to see a record of all the activity to date that builds towards each requirement. Another step is to ensure that staff are knowledgeable about risk for readmission and that there is evidence-based medicine guidelines to support the team, as well as the provision of chronic care management. Some of the steps you see here have to do with training staff on the specific care model, implementing the evidence-based guideline. Again, a variety of sub-steps will need to be added to flush out the detail here, such as developing the agreed upon definition for the risk assessment and what types of patients are eligible for the hospital-to-home collaborative solutions project. Additional requirements include developing the care pathways and the clinical tools and educating staff on those pathways. Two more requirements are to develop advanced care planning tools to document near and end-of-life care wishes. Some of the steps that will need to take place here are steps such as looking at what advanced care planning tools and procedures are already in place with all the various partner organizations, looking at those as a whole and coming to a consistent common approach to advanced care planning. Another requirement is to create a coaching program to facilitate and support the implementation of the project. Educating patients and family members or other caretakers to participate in the planning of care, as well as integrating primary care, behavioral health pharmacy, and other services into the model. Two more requirements are to utilize telehealth, telemedicine in order to enhance the collaboration project. We've set a target date here for the end of 2016. An additional requirement is to utilize interoperable EHRs to enhance communication and avoid medication errors and/or duplicative services. For this particular requirement, we're using the target date of March 2017, which, as I mentioned earlier, is the date by which all of the project requirements need to be met. So that's the latest date that we can use for any of these sections. Another requirement is to measure outcomes in order to identify any additional interventions. The first step here is to form the quality committee. The target date for that is December of this year, because this has to align with the governance milestones that DOH has preset, one of which is that clinical quality committee structure must be in place by the end of this year. Once that structure is in place, it'll be the clinical quality committee's responsibility to identify opportunities for quality improvement and create and evaluate action plans to make needed improvements and be able to report out on the quality outcome measures to all stakeholders. Finally, the last requirement is to use EHRs and other technical platforms to track all of the patients engaged in the project. The first point in time that this PPS is required to report a number of patients that have been actively engaged, that is, what did we commit to in our speed and scale commitments for actively engaged, that the first report of actively engaged is September 30th of 2016. Therefore, that's the target date that has been set for being able to track actively engaged patients. That's not to say that the program cannot be operational before that date. It's simply that's the first date by which we will need to have a process in place in order to be able to track. So let's move on now to risks and mitigation. For all the different projects that PPS reports risks and mitigation strategies. For hospital-to-home collaborative solutions, one of the risks is coordinating and managing the various initiatives, programs, and resources that are available to all patients. If the patients and the providers lack the information and tools needed to quickly identify the resources needed, this could delay servicing additional patients and overall slow down the implementation. So the mitigation strategy is really to ensure that all the members of the rapid response team have in place the tools that they need, such as a resource guide, so that they can readily access the information on needed services and be able to make decisions effectively. Another risk is that the data that is acquired can be may be difficult to utilize due to disparate reporting requirements. If we have dissimilar data coming out of disjointed data collection systems, this will impact the quality reporting and really slow down the overall improvement process. The mitigation strategy is to utilize a common PHM platform and to standardize the data collection and reporting process. Another risk is the inability to share health information in real time among the members of the care team. So that, that lack of being able to communicate across partners in the team could lead to delays. The mitigation here is, again, a technological mitigation, providing mobile technologies or other tools so that the members of the team have access to the information they need at the right point in time is an important mitigation strategy. Another risk to this project, which is common risk with other projects as well, is the risk of provider shortages. We have we're in the midst of rapid change in the healthcare environment all across the country, but particularly in New York under DSRIP. And the providers in our region have already gone through substantial changes in the past several years. Many transformation initiatives have been underway, and there's really there's a shortage of providers in numbers, as well as a shortage of overall provider time to be taking part in the development of these new care models. One of the mitigate this issue is work with the workforce committee on the workforce issues. A final risk I'd like to mention would be lack of a common identification of the region. methodology. It'll really strain our resources and result in a difficult to evaluate program as well as some inefficiencies. So the project team will be working together as a regional group to define that common identification, priority stratification methodology for access to the program. Questions, as Heather mentioned at the beginning, gathered for this particular project. And finally, I have some instructions on how to provide feedback. Feedback can be sent to AHS via the DSRIP mailbox. You see the mailbox address shown here. And feedback within a week by the 21st in order to ensure it gets incorporated into the 731 submission. Use the subject feed. Please keep in mind we're gathering feedback on some 11 different projects, and be sure to specify which project you're referring to. In addition, the actual implementation plan draft, so today I showed you some requirements and steps as well as target dates. A Word document of that implementation plan will be posted on the website. Should you want to download that and use it directly to make any edits and return as an attachment, we would very much welcome that. Should you have feedback that's more brief and you just want to send an email to us, that is welcome as well. And I thank you for taking part in today's webinar on hospital-to-home collaborative solutions.
That concludes today's webinar. Thank you very much for attending, and we hope you have a great rest of your day.